gives me great pleasure to introduce to you Dr. Mangla. Dr. Mangla is going to talk to you about epidemiological principles, and as a doctoral student in epidemiology, this is definitely a topic that's near and dear to my heart. Many of you may find epidemiology a little intimidating. It's a big, long word, and it sounds complicated. So that's exactly why we're offering this session today. Dr. Mangla is going to provide you with some tools that will empower you to apply these concepts and principles to your daily practice, whatever it is that you may do, whether that's evaluating new research studies that are released or evaluating stories that you may hear in the local media, or if it's something as simple as identifying disease clusters. So before I turn it over to Dr. Mangla, I just wanted to read his introduction. Dr. Mangla is currently Assistant Director and Chief Epidemiologist at Metro Health. He is an adjunct associate professor at UT San Antonio School of Public Health. And prior to this appointment, he was the Director of Infectious Disease and Immunization for the Georgia Department of Public Health and acting state epidemiologist for Georgia. He also serves as an adjunct associate professor at the University of Georgia, Athens, and assistant professor at Mercer University School of Medicine. Among many of Dr. Mangla's accolades are Outstanding Young Minnesotan of the Year Award in 2001, recipient of the Bush Leadership Fellowship in 2003, Outstanding Community Recognition Award in 2005, and Fellow of the Royal Institute of Public Health. In 2005, the U.S. flag was flown over the U.S. Capitol to honor Dr. Mangla's work in global health and to the citizens of Minnesota. In 2007, he was awarded the GlaxoSmithKline Child Health Recognition Award. So I think we can all agree he's very well qualified to give this presentation.
Thank you. Thank you, everybody. So my goal today is I want to kind of add epidemiology terminology, epidemiology tools, and look how disease incorporates with epidemiology and how we use that to actually do disease prevention, disease isolation. So I'm going to kind of give you a very broad picture of epidemiology. You know, 45 minutes or 40 minutes is not enough time, but you'll get a picture of what I'm actually looking for. This is just a slide for, I don't have any interests, any conflicts. I don't work for any pharmaceuticals, so that's kind of giving you that. So the goal, what I want at the end of this seminar is to decrease the fear factor of infectious disease among all of you. So what I would like when you leave here, you should be comfortable in thinking that there's no fear of infectious disease getting into your community. That includes Ebola, because you know how there's been a large amount of propaganda. And I think we have absolutely no outbreak here, and I'll go a little into detail with that later. So how I'm going to accomplish this is there's few objectives I'm going to cover, which are basic terminologies, definitions. Then I'm going to show you how we use data in epidemiology in tracking disease, but more to use that as a almost roadmap on how to accomplish better rates and where there's a shortage of vaccination or antigens within different counties and different zip codes. And then what I'd like is a discussion or kind of leave the end open to questions. So what is epidemiology? And a lot of people will think epi means epidermis, skin, so it's the disease of skins, right? But it's not. And I promise that's what I thought 25 years ago. But more than that, it's actually looking at distribution, and it's looking at different health states or morbidity, mortality, looking at teenage pregnancy, looking at certain infectious disease, and how that differs or varies within zip codes, within populations, and even within gender. So I'll give you some examples of what we have identified from the current data we have for San Antonio. In epidemiology, we look at 5 key principles which journalists also look at, and it's called the 5 W's. So it's what, who, where, when, and why. But in epidemiology, we ask a little different questions related to those 5 areas. So what event or what disease are we trying to isolate? The second thing is person. So who got it? Is it one person? Is it a community? Is it a county? And so then comes place, as we were talking about, time in place. There's a disease, or the rate of HIV is 20 cases per 100,000 during 2007. So we look at time, which is very important because we can compare trends. And finally, what are the causes? So I'll talk about one of the key things we look at is a web of causation. And that's a terminology, but I'll give you a very good example on it. And then modes of transmission. And this is so important. And, you know, I worked with the United Nations for 3 years. And when we went for our initial training, people had asked me, aren't you scared going to these countries when you have all this disease? Yes, you are. But in your training, what you trained with is identifying the risks of each disease, respecting that disease, understanding its modes of transmission. And when you get that concept of a disease, you almost seem to forget how risky it is, because you're going to be very proactive in dealing with certain diseases. And so that is key, what I was bringing up when I talk about epidemiology. So in EPI, we have what's called the tenets of epidemiology, and this is a key concept when you do outbreak investigations. Now, most of you are not from San Antonio, but I can be very proud in saying for the past 3 years, we've had absolutely no outbreaks here. And we've had no outbreaks because of these methods, these skills. So I have an epidemiology section of about 8 people. And what we do is if we get a report of an infectious disease, we find that disease. What disease is it? So you do a confirmation. Isolate. Isolate meaning identify the individual and isolate them in a hospital setting. Identify their contacts, and you want to make sure you identify contacts because you don't want the spread in a community. And then stop any other exposures that occur in a community. And finally, put some control measures so to ensure that that does not happen again. So that kind of is giving you a concept. Now, when we're looking at isolate, I want to bring up something that a lot of people are confused with, and I think this goes right back to media. And sometimes media don't know definitions of these words they use. So if you've heard about the Ebola outbreak, you heard 2 words used continuously: isolation and quarantine. And I think a lot of people use that concurrently, but they mean very different things. When you isolate an individual, what you're doing is you know the person is confirmed with a disease. When that disease is confirmed, mumps, measles, Ebola, that's isolating an individual. What's quarantine? Quarantine is used when a person is exposed or may be exposed, but does not have the disease yet. So you use quarantine. And the third terminology that's used very often is monitoring. So monitoring is following an individual for a period of time to see if they get any symptoms. So if you remember the nurse that was in Maine, she had a quarantine order which was absolutely unnecessary. But it was important for her to be monitored before she gets symptoms. Now I'll tell you why and why that is important and why politics should not play a role in this. Leave it to public health, because when you talk a disease, there's few things that happen. A person is always susceptible for some disease, right? They get infected, there's 2 things that's going to happen. You're not going to make it, or you're going to recover, right? When you recover, there's 2 things that happen there. You build your immunity. A good example, chickenpox, measles and mumps. You get inoculated, you build the antibodies, you ain't getting that disease again. But think of flu. When you get flu, you get infected, you recover, and you're going to be susceptible again. So things with flu, you take a vaccination every year because you're not immune all the time. That's why it's important to take that flu shot. And I'll talk a little why to take that flu shot, because the strains change. And I'll give you an example of that in some of the following slides. So this is a very important slide, and I think this is the main slide that a lot of politicians should actually learn. So when you look at a timeline of disease, normally you have an infection. So someone gets exposed, they get infected. You go through what's called an incubation period, which is very important. An incubation period is where the germ or the virus or the bacteria uses your body as a host to start multiplying. It comes to a certain stage where you start seeing symptoms or you start seeing clinical onset. And that's when you get disease, you get your disease, and you'd recover, or again, you won't make it. But here's the important thing when you look at incubation period. If you see this line here, infectious. When you look at mumps, measles, and the flu, you are already infectious before you start showing symptoms. So if I got the flu today, I can spread it to everybody, not even knowing I'm sick. When you look at Ebola, you're not going to spread that virus till you become symptomatic. That's why there's no requirement of a quarantine. It's monitoring, because once you monitor an individual and they start showing symptoms, that's when they become infectious, not like the other diseases. So you can see when you learn about a disease, you respect where the risk is and what to do and what not to do. So that's why I bring up, this is a very important slide. Going on, in public health, we do a lot of surveillance, right? And there's 3 different surveillance that we do all the time. Is active, passive, and sentinel. Active is when we would monitor someone or call a physician and try to find contact investigations. Passive is when a doctor's office or a hospital's lab are reporting these to us, which are mandatory on maybe 24-hour basis during weekly or monthly, depending on what disease it is. And then sentinel is where we work with certain providers in the city to provide us their data, for example, their flu shots. So what we do is they'll take a flu sample from a patient that we will analyze. And sentinel means we will have maybe 12 providers around San Antonio, so we'll have a good distribution of what strain is predominant in the city. And so that would tell us what type of season we're going to have. So you can see how epidemiology really helps track disease and let us know what to do as we kind of look at that progression. So this is an example of the reportable diseases in Texas, but this is just part of it. But you can see some need to be reported within 1 work day, some immediately. So it depends on the severity, the contagiousness of the disease. It would, require immediate reporting or maybe not. So this is passive reporting, and I was the state epidemiologist in Georgia, and so this is a system we had, which is a notifiable disease. So providers would enter their disease, their patient name in this, and this would come direct to my iPad, iPhone. So if it was mumps, measles, TB, there wasn't Ebola then, but we could react immediately. Now nowadays what we do is even schools, what schools do is they call us and then we act immediately. And I have one of my friends who's a school nurse here who understands how that works. So it's, again, a similar type of a sentinel system. So in diseases, what happens is someone gets exposed in the population, they get sick, they seek care, go to a provider, they take a blood sample, that's sent to the lab confirms it, that's sent to public health, and then we start an investigation. So you can see the pyramid of how the roadmap of outbreak investigation starts. So outbreak, let's talk a little about outbreak. Now, outbreak is what? How is outbreak used? So I think that term is used out of context. An outbreak is something that occurs where your baseline of a disease, say it's 3 or 4. An outbreak is 2 standard deviations above your baseline. For some diseases like smallpox, even if it's just 1 case, you could regard that as an outbreak because you don't see that. If you remember with Ebola, they talked about an outbreak. That was not an outbreak. It was 1 case that came in this country. Even if we went to 10 cases, it would not be an outbreak because Africa has hundreds and thousands of these cases. So you got to kind of think of it in that context. How do we get data in epidemiology? So there's a variety of ways that we actually collect information. So collecting information and analyzing it. So how do we analyze? So you can see there's few terms we use. Frequency is a count. It's a hard number. 10, 40, 60 cases. Percent is when we compare different populations, different genders. Rate is very important because rate allows us to standardize the number and compare different cities, different states. So here's an example I'll just throw out of what a frequency means and what a rate means. So if there's a small city in Texas with a population of 1,000 and they get 15 cases of measles, there's another city of 4,000 in that population that has 60 cases of measles. You'd initially think, wow, 60 cases, that city has much more cases. But in reality, when you look at rate, they're the same, they're identical. So what rate allows us to do is standardize these numbers to ensure that we can compare correctly one city to another, one zip code to another, and so forth. So this is a good example I'll give from our own data. So when I got hired 3 years ago, my main goal or my most important responsibility was to decrease the syphilis rate in Bexar County. I don't know how much you guys know, but we have the highest syphilis rates here. That's why we call the party town, right? So for the first time last year, if you notice, we actually have decreased our numbers. So our numbers are going down, so it's becoming a boring town. But I'm kidding, nevertheless, even with that decrease, if you look at rate, you can see that San Antonio is still 3 times higher than the national and state average. So we still got a lot of work to do. So it'll take a few years, so make sure that you remember we still party a lot here. Especially fiesta time, okay? But here's the important thing. In Epi, we can also use GIS to map where we can look at targets and we can look at where we need to implement programs. So if you look at this is the syphilis cases in Bexar County, and if you look at that area, that's where there's all the drug dealers and prostitution occurring. So we really focused and allowed our hospitals to have implemented programs in this area so we can actually identify pregnant women with syphilis, not having congenital cases, but to treat that women to 100% prevent that syphilis case. And all we had to do was make sure we focused our efforts in that area. So it's working. And the only way we made it work is look at the data in epidemiology and come to some conclusions, right? So, two other terms that are important, incidence and prevalence. So the easy way to remember this is incidence is all new cases that occur. Prevalence is new cases plus existing cases. A good example is the one with HIV. You can see prevalence is something that keeps going up because it's all new cases plus existing cases. And in HIV, it's demonstrated really well because when the AZT, which was the drug that came out for HIV, the amount of deaths started decreasing. The number of cases started decreasing as well because of we had a case definition at that time. But prevalence kept going up because that was people started living longer, and then you also had your new cases. So you can kind of see the concept there. Causation. So how does a disease occur? For someone to get a disease, you must have a cause. You must have an effect. The effect could be a germ. It could be an environmental exposure or something. But there's also other things that cause disease or cause mortality. And if you look at this, let's take lung cancer, right? You can see lung cancer could be related to environment, smoking, your occupation, your diet, heredity. But your diet in turn is also related to your heredity. So when we do a study to identify what is the causative factor for lung cancer, what we do is we look at every one of these indicators and then we look at confounders. So these are called confounders, and we adjust to make sure that is there one specific association for this or many. Now that is important because if you look at HIV, you can see the web of causation. There is a lot of factors that play a role. That's why this disease was such a complicating disease to work with, because there's so many factors that played a role in people getting this disease. Okay? So let's move on and look at how we use epi for vaccinations. So this is a really good graph, and I boast about this because when I was in Georgia, we ranked 37 in the country, right? And we brought Georgia up to be #1 in the country in 2011. And we used this because we used epi. We saw where we had our barriers, gaps, lack of antigen use, and we used it very constructively to make sure that those gaps were closed. Now in San Antonio, we're still a roller coaster. See that? So hopefully I'm going to try to get us to #1 in the next few years. Is it possible? Absolutely. How? We identify where these gaps are, what the percentages are, why the gap is there, and then work very close on that. So you can see how important data is. Same thing with flu. We can identify where we have a lack of flu coverage, and that can be broken up by age, race, and then focus on specific groups. This way, we can also look at a flu season. So normally, in January, many people tell me, oh, I don't need the flu shot, it's too late. No, it's not. Your flu season normally is from November to May. Your peak is in February. So it's important to get that shot anytime. The sooner the better, because it takes a month to build those antibodies. So you want to make sure you get it by October, November. But it's still never too late to get it in January, February, because some seasons go right through up to May. This is good, and this is the map of the state of Georgia. But why this is important is it shows you the importance of a flu vaccine. So if you look at the blue dots, it's all vaccines that were administered in that region. The rate tells you the amount of hospitalizations within that region. Regions that did not take part in the flu, school-based flu program, you can see there's no blue dots there, very minimum blue dots here. They have a bright red, that means they had the highest hospitalization rate. So it's a very clear indicator of more vaccination allowed them to have less cases, casualties when it came to flu. The other important thing we identified in Georgia is graduation rate. Look at the number of days absent in relationship with their graduation rate. So when kids were out of school 15 days or more, the graduation rate reduced to almost 34%. That's why we have supported and promoted flu vaccines in schools to avoid absenteeism. So that is kind of crucial, which we actually doing over here. This is another important slide when we look at epidemiology. So when you look at epi and a flu shot, you normally have two A strains in there and a B strain. When research was done, they identified that there was, in many of these seasons, there was another B strain that circulated that was in the air but not in the vaccine. So nowadays what we have is called a quadvalent flu vaccine, which has the two A's and two B's. So you get much more immunity in that way. So public health's role, and I'm going to go, I got enough time, right? Okay. So how do we do prevention? There's a variety of ways we do prevention. So as you can see, improve vaccination rates, make sure we have a good response team for an outbreak and so forth. But when you look at disease, these are kind of the A networks in 1930. These are the networks now. So you can see for a disease to come from one country to another, it's just one flight away. So are we going to ever see Ebola in this place again? Yes, we are. It's a matter of time. Maybe not next week, not next month, next year, but we're going to get it. So be proactive and get ready and understand the disease so people are not fearful. And that's kind of my goal. When you leave today, I want that fear factor to diminish because you understand that disease. So vaccine coverage, you can see the coverage today is much better than when it was in the 60s and 70s. This is herd immunity, very important when we talk of vaccinations. So what this tells you is these are two people that are not immunized and are sick and contagious, right? The rest are healthy but not vaccinated. Look what happens. A lot of people get sick in the community because of just these two. In this, you have the yellow is some of them now got vaccinated, right? As you can see, the community is still getting infected, but not as much. Now, in a community, when you get 80 to 85% of the community vaccinated, that's called herd immunity. What that does is it really helps the ones that are not vaccinated. And disease spreads very slowly or not at all. And so it's important in schools to get these kids vaccinated because they're the vectors. They're the ones that are bringing it home and you're getting sick at home. So if we can control it in schools, then you're going to have a less likelihood of parents getting sick. So, that's again to do with the herd immunity. Right? Same thing with the measles thing we had in Tarrant County a year ago. What happened here? A pastor flew internationally, came back to his church, and his church believed in non-vaccines, and he contaminated and infected 16 to 18 others. So you can see that. We heard of polio, right? I'm going to go real fast here. And we know what polio is. It's something of the past. It's very infectious. It causes paralysis. As you can see, polio is almost eradicated in the U.S. The symptoms are normally like flu-like symptoms and paralysis. Transmission, again, it's very contagious. But here's the important part. It can spread before symptoms show up. That's the key that is not in Ebola. That's why this is actually more contagious than Ebola, because the symptoms are not present when the infectivity is. Now, to tell you something is we actually had a case in San Antonio, which is a shocker, right? We published this with the CDC, and how this occurred was a child that flew internationally, picked it up in another country, came back, and he had it here in San Antonio. Our task immediately was to isolate the hospital, isolate the child, prepare all the first-line healthcare workers in that hospital, and guess what? Nobody got infected. There were no community or hospital transmission because it was acting appropriately and efficiently. Right? So I'm not going to go into too much detail, but here's the case study which, if someone wants these slides, I'll be welcome to share them. What I do want to bring up is something about Ebola real quick. So I want to make sure that people don't have this fear factor. So it's a virus, right? There has been many outbreaks in Africa. The way it's transferred is a fruit bat transfers it to animals that transfers it to humans. Now, if anybody has been to Africa, you have butchers on the side road. And so a lot of meat is sold on the side of the road. Push meat. People buy this, and that's how you get contaminated. Now, if you look at where Ebola is, it's in a very small place in Africa. You can see how big Africa is. So when people say, oh, I just flew in from Africa, don't touch me, you got Ebola, that's wrong. Right? It's 3 countries in Africa that's almost like New Hampshire, and that's about it. What occurred here in the US? So you know Mr. Duncan flew to the US, went to Dallas, went to the hospital, was sick, misdiagnosed, sent him home. He stayed 3 to 4 days at home, came back with severe symptoms, very infectious, and infected the 2 healthcare workers. Well, there were about 100 workers that actually, or healthcare providers with him, but 2 got infected. After that, CDC decided that they should not use semi-porous gowns, but full gowns. So you can see there was a lot of gaps in that system. Now, if you look at Ebola, it's not contagious. You can see here's the contagious, it's called a R factor. Mumps, measles, SARS is much more contagious than Ebola. But what Ebola is, it's very infectious, meaning if you get exposed to it, the chances of you getting Ebola are very high. So that's kind of the difference. How is it transmitted? So there's 3 things you need to remember. It's not airborne. Someone is only infectious once they become symptomatic. Now remember when I said, here's the exposure. Someone goes through an incubation period, right? The incubation period is anywhere from 2 to 21 days in Ebola. The 2 and 21 are outliers. Normally, people will show symptoms between 10 and 12, 10 and 14 days. The first nurse showed it in 10 days. The second nurse showed it in 13 days. So that's kind of the average. But look at the Ebola thing. Only when you're symptomatic does your viral load meaning the virus in your system, start increasing. So number 1, it's not airborne. Number 2, it's only infectious once symptoms start, and that even after about 72 hours. And third, you must have direct contact with someone's bodily fluids. If that doesn't happen, you ain't getting it. But let me go back to this slide. Now you can see why it's important to know the disease, because other diseases are infectious before you show symptoms. This one is not, right? Viral load is the highest when someone dies. In Africa, the major issue for that outbreak was the lack of hygienic burial and funeral practices. Now think of it. Here's a person who passed away. They don't do embalming there. There's a body that's laid. People are hugging it, kissing it. Guess what? At the most contagious, most infective part, that's what they're doing. 3 stages for Ebola. It's that severe. If you start symptoms and you don't get treated, you don't have more than 10 to 14 days to live. That's how quick it goes through your body. So very severe in that way. What are we doing in San Antonio? We actually put in policies and guidance here in San Antonio even before the Dallas case. So how we did this was, this is what we have decided to do. The gatekeepers for this disease are the health department, EMS, and the hospital ER. So if you ask EMS at dispatch, anyone calls, there's 2 risk questions you ask. Have you traveled to West Africa in the past 3 weeks? If you have not, you don't have Ebola. And I say that very clear because we do not have community transmission in the US. It's not community. The only people that got not community transmission, but transmission were the 2 healthcare workers. Mr. Duncan's family did not get exposed even when he was sick at home. But that was because he was still at that stage 1. So no community transmission, so you really don't have to worry about anybody calling EMS who has not traveled to get Ebola. If they have traveled, the second risk question is, do you have a fever? If that is the case, then we will transport them to ER. So you can see we have really a lot of policies in place. But on that note, I want to kind of, thank a few people that have done a lot of work. We're very confident here in San Antonio, and I hope all the other local health departments are the same, that if we do get Ebola, it's not, it's going to come or not, it's just when. We are already proactively having these things in place where we're going to know how to work on it. Now, Ebola is not any different from everyday work that we do with mumps, measles, TB, which are much more contagious. Any of those reports that come in, we really isolate, do the partner tracking, and make sure there's no outbreak or no spread. It's not any different with Ebola. As a matter of fact, it's much easier to contain. It's very infectious and deadly, and that occurs within few weeks. But I think it can be contained. There's a lot of lessons learned. But the key here is, don't fear. The day the health department calls you that you were a contact, you start worrying. Till then, you don't worry about it. So, thank you for that.